بسم الله الرحمن الرحيم. طبعا احنا النهارده في غايه الشكر والامتنان لاستاذنا الدكتور وسام اسماعيل، استاذ نفروباثولوجي في جامعه بني سويف، وطبعا هي علم وممثل رائع لمصر في الجمعيه الدوليه لامراض الكلى في الباثولوجي شابتر. فاحنا النهارده ان شاء الله هنستمتع، هنبدا الموضوع من اوله خالص، وان شاء الله على وعد من الدكتور وسام بحلقات متعدده بحيث الناس تبقى اوير بالباثولوجي. لان انا بقول ان دكتور النفرولوجي اللي مش اوير بالباثولوجي بالنفروباثولوجي ما يبقاش دكتور كلى مكتمل، ولازم يبقى هناك دايما ديسكشن مع الباثولوجي. وزي ما استاذنا الدكتوره دولت بلال كان بتقول قبل التسجيل انه ساعات بيبقى الدايجنوستس غامض، وان الباثولوجي بيحل كتير جدا من المشاكل اللي بتقابلنا. فطبعا احنا والباثولوجي كلنا بنتكامل بحيث نوصل لدايجنوزس يفيد العيان ويبقى له جود ريفلكشن على المانجمنت. انا بيسعدني وشرفني وجود دكتور وسام النهارده، ودي بدايه الحلقات، وهسيب لحضرتك بقى المايك بحيث تتولي المحاضره العظيمه النهارده ان شاء الله. اتفضلي يا دكتور وسام.
حسين، وميرسي على الدعوة الكريمة، ويعني الشرف ليا ويسعدني جدا ان احنا يعني يكون على حلقات زي ما حضرتك قلت، وان احنا نتناقش مع زمايلنا الصغيرين وناخد فكرة عن الباثولوجي واهمية الرينال باثولوجي for the nephrologist as you say. طيب احنا هنبتدي النهارده with an introduction. The introduction would be general. Mainly discussing renal biopsy techniques. I'm not going to bore you very much. You might be just a little bit bored about the renal biopsy techniques, but I think they are very important information for you as a nephrologist to know, as well as of the pathologists who are joining us today. And then we're going to talk about patterns of glomerular injury in general, just to have an idea before we start, inshallah, later on in the following episodes to discuss the diseases in detail. Okay. Now, before the renal biopsy, we discovered how to do a renal biopsy. It was really hard to conceive how renal pathology was understood prior to the renal biopsy. Percutaneous needle biopsy for light microscopy and integrating immunofluorescence electron microscopy was basically discovered between 1950 and 1970. And it is through this technique what provided the structural basis for diagnosis of the many different aspects of renal diseases that had been impossible to classify in an orderly fashion before we knew how to take a renal biopsy. Why do you take a renal biopsy? A renal biopsy is not only for accurate diagnosis. It plays a critical role in the initial treatment, prognosis, and response to therapy of your patient. It is the most important tool in the management of patients with acute kidney injury and chronic kidney disease. I know that very few patients with acute kidney injury undergo biopsy. However, clinical diagnosis of AKI is actually incorrect in around 50% of cases. And it's even less with chronic kidney disease. For example, diabetic patients, only 10% are biopsied, when you have up to 2/3 have a different diagnosis other than diabetic nephropathy. So what do you want from the biopsy? Diagnosis? Is this all what you want? You have already your clinical diagnosis, so you want etiological diagnosis, and a pathological diagnosis. Do you want prognosis? Can the biopsy give you prognosis? Yes. And do you want a guideline to treatment? Yes. And I'm very clear, a guideline to treatment. But the pathologist is not going to tell you how to treat your patients or what you give your patient, but it gives you a guideline on the possible treatment because it gives you more or less a diagnosis with prognostic factors. Let's take an example. This is a 30-year-old male, known lupus, who presented with a serum creat 5.8 from 2.4. His C3 and C4 was low, and he had a proteinuria of 3 grams per day. He had a previous biopsy 6 months ago, and this biopsy showed secondary FSGS lesions, 40% global sclerosis, and 15% interstitial fibrosis. Now, what's your diagnosis? We can have 2 answers. Dr. Hussein, what's your diagnosis?
For this 30 years old male SLA presented with creatinine 5.8 الفروم 2 و4 يبقى هو البيزل بتاعه سي كي دي، والكرياتين زاد من 2 و4 ل 5.8 يبقى ده يا اما بروجريشن للسي كي دي، انا مش عارف من امتى كان 2 و4 ده، يا اما في اكوت انسلت. فالبيوبسي
6
هنا
شهور.
البيوبسي از مانداتوري لانها هتخليني ككلينيشن ممكن ما اديش اجريسيف تريتمنت اللوبس نفرايتس اذا كان ده الباثولوجي طلع، فانا
Yes.
محتاجه هنا.
But most of us would doubt that the patient is in a form of activity, even activity on top of the chronic kidney disease.
صح. لكن البيوبسي هتبقى
وفي ناس
الفيصل.
كتير هتقول لك بالظبط، الناس هتقول لك كتير he has low C3 and C4, we know his lupus, he has renal impairment وبروتونوريك and so on, why should you biopsy؟
لان المفروض نفصل ما بين
احنا
استاذن حضرتك، انا ككلينيشن ببص لنقطتين. انا عندي باثولوجيكال او باثوجينيتك بروسيس شغاله، فالاوتو اميونيتي مش هتختفي كلها، او الاندكس بتاع الاميون بروفايل مش هيختفي، لكن المعركه انتهت بكرونيسيتي عنيفه في التيشو. انا اشتغل ليه اجريسيف تريتمنت اذا ما كانش عندي اذر سيستميك اذر مانيفستيشن. تمام.
Exactly. So as you can see, the patient is very active. ما حدش فينا اختلف على النقطة دي in that has. But what information did the biopsy provide؟ زي ما الدكتور حسين، الactive lupus, which class, activity and chronicity indices, does the patient have crescents? Do you need to go aggressive زي ما الدكتور حسين بيقول, or you don't need to? The percentage of activity. Why is the creatinine 5.8? زي ما الدكتور حسين برضو قال, is it end-stage renal disease? Does the patient has associated vascular lesions as thrombotic microangiopathy? He had some neutrophils in tubular interstitium. Does he have an associated infection? All of this is your prognostic factors. And this, as you said,
this will... عندنا بعد اذنك يا دكتور وسام، في احد الناس كاتبين على الشات if the kidney size is small. لو الكدني size small انا مش هعمل بايوبسي حتى لو العين لوبس. يعني يعني انا لو عندي عيان عنده سيستميك لوبس ارثماتوزس والاميونولوجي بروفايل بوزيتيف والكدني سايز سمول سايز، ده من الفيو اكسبشنز اللي تخليني مش هعمل بايوبسي، وان انا اعتبر ان ده اند ستيج كدني ديزيز في لوبس نفرايتس، لان هتبقى البايوبسي هتضيف ليتل يعني. اتفضلي يا دكتور وسام. دكتور وسام.
It's a 25-year-old female. ايوه معاك.
الصوت ساعات بيعلق. اتفضلي.
معلش. This is a 25-year-old female with a postpartum diagnosis of HELP, acute renal failure, and she initiated plasma exchange. أي حد عنده doubt that this is thrombotic microangiopathy? I doubt. We all know that this is TMA. And she does have TMA. So why did we biopsy? We biopsied because we wanted to see her blood vessels. Because in this scenario, the blood vessels is what's going to give you the prognostic factors. So even when if you have a clinically overt case, when you know what's happening with the patient, when you know probably what you're going to see in the biopsy, you still need the biopsy because it's going to provide you with the prognostic factors and the treatment guideline you want, whether you should continue treatment, whether you should give aggressive treatment, or just leave the patient alone. Okay, what I'm going to discuss today in relation to the techniques of the renal biopsy, following the guidelines of the technical procedure manual we had put in the renal pathology working group in the ISN, and it's published on the ISN website. Also to the ad hoc committee on renal biopsy guidelines of the Renal Pathology Society, and it's also present in Herpenstahl primer on renal disease. So these are the references for the data. Okay, let's start by step number 1. You obtain the tissue, and you want to know if you have an adequate specimen. Bedside examination of the renal biopsy. You can do it. It's not a big deal. Now look at this. This shows you glomeruli in unfixed cortical tissue. And here, this is medulla. How do you examine it? You can use a magnifying hand lens or a dissecting microscope. And I'll make it even more easier for you. دلوقتي كلنا عندنا smartphones. All smartphones have magnification apps. Just download the application with the magnifying lens, look at the core, and then you know that this is cortex. I know, of course, that most of you by now do not take the biopsies and that the biopsies are taken by the radiologist. But if you can get in contact with your radiologist and tell him this is a very simple info, and they can train themselves to see it, and this will really makes a difference, and it decreases the rate of failed biopsies at least by 50%, because then he knows he's having medulla, you still have the patient, and then you can proceed with another core. Now, it is the responsibility of the pathologist to produce an accurate morphological diagnosis. But by the way, it's the responsibility of the nephrologist to provide an adequate biopsy and complete comprehensive data. So it's a conjoint responsibility. It's not only our responsibility. Renal biopsy is an invasive technique. Always remember this. So if you're doing an invasive technique, even with a minimal risk of complications, you need to make sure that you're going to do your best to get a diagnosis out of this invasive techniques. So push for a diagnosis, push for 2 to 3 long cores, use 16 gauge needles. This is a study which showed the prevalence of insufficient material as a function of needle thickness. Out of 1,000 biopsies, when they used 16 gauge needle, they had inadequate biopsy in 6%, while in 18 gauge needles, they had 12% with respect to glomeruli and 35% with respect to arteries, in spite of that they had 2 cores. Automatic biopsy devices usually yield 50% medullary tissue. So the guidelines now, and these guidelines are published, and these are the references, that the recommended biopsy needle size is 16 gauge needles. This will give you more glomeruli, more diagnostically adequate tissue, fewer cores to obtain, and fewer repeat biopsies with no increase in complications compared with 18 gauge needles. So make sure to inform or write on the request for your radiologist that you do not want a biopsy with 18 gauge needle and that he should use a 16 gauge needle instead. So now specimen adequacy is usually about whether we have cortex or medulla and how much cortex do we have in a biopsy. Why? Because then it's cortex which has the glomeruli, and most of diseases in concern in relation to a renal biopsy are glomerular diseases. So an adequate biopsy classically in a native kidney is a renal cortex containing a minimum of 8, preferably 10 glomeruli. While in transplant kidney, the adequacy is different. We need 10 glomeruli and 2 arteries with a minimal sample of 7 glomeruli and 1 artery. Focal lesions versus diffuse lesions.
استاذنك يا دكتوره وسام، استاذنك سؤال هنا.
اتفضل دكتور حسين.
الوقت انا ساعات بنقرا الريبورت بتاع الباثولوجي او بنشوف او بنتناقش مع الباثولوجيست، فيقول لك انا عندي سيريال سيكشنز والسيكشنز الجلوميرولاي من كذا لكذا. هو احنا بنعد الجلوميرولاي في التوتال ولا بنعدها ازاي؟ يعني ايضاح بس للنقطه دي.
لا، احنا بنعد الجلوميرولاي في اكتر سيريال سيكشن في نمبر اوف جلوميرولاي.
يعني بنريبورت اقصى الماكسيمم نمبر ولا
الماكسيمم نمبر؟ يس.
ما فيش داعي ان انا اقول مثلا من 5 ل 10 الكلام ده.
لا،
يعني
مش كولكتيف.
لا
الكلام ده doesn't make sense. انا هنقول ايه اهميه النمبر اوف glomeruli that we see.
تمام.
انا صوتي واضح؟ انا ممكن احاول اعمل حاجه تصلح. تمام. طيب
تمام، اتفضل.
اوكي. الadequacy of the specimen بتفرق between focal lesions and diffuse lesion. يعني ايه الكلام ده؟ يعني لو انا I'm considering a focal lesion، لو انا واخد البيوبسي دي عشان عايز اعرف العيان اللي عنده steroid resistant nephrotic syndrome ده يا ترى minimal change ولا FSGS، then this 10, the number of glomeruli 10, which is the classic definition of an adequate biopsy, is not going to work. Because if I have a biopsy with 10 glomeruli and I'm considering a focal lesion, then I have and this focal lesion only involves 10% of the kidney, I have a 35% chance of losing it. I'm not going to see it. And if this focal lesion is even more advanced, with FSGS involving 25% of the kidney, again, in a biopsy of 10 glomeruli, I still have a 5% chance of missing the lesion. I cannot tell you a specific cutoff to say how much is the number of glomeruli which should be adequate with which we can exclude a focal lesion. But at least we cannot really exclude a focal lesion except if we have a number of 20 glomeruli. However, in diffuse lesions as membranous, if I have, for example, amyloidosis, if this is a post-infectious GN, so you can make the diagnosis out of a single glomerulus or a 3 or 4 glomeruli. But bear in mind that this is just a diagnosis. You do not have any prognostic factors. You don't know if the patient has any chronicity. You don't know whether the patient has any activity, whether this post-infection has crescents, necrosis, has interstitial fibrosis. You don't really know what is there. So the number of the glomeruli in the biopsy gives you an idea on how accurate the pathologist report may be in relation to the size of the biopsy. So this is why we add a number, and this is why we target to count the maximum number of glomeruli we have. So this is, if we have 15 glomeruli in the biopsy and you're looking to exclude FSGS, then you know that you still have around 10% or 5% chance of losing it. If the biopsy has 8 glomeruli and you're looking for FSGS, so you definitely have almost a 90% chance that the FSGS was not represented in this biopsy. So this is why we add the number of glomeruli. This is also important in crescents. If you want to know the percentage of activity, if I have a biopsy of 5 glomeruli and I say I have 1 crescent, this does not mean 20% crescents, by the way. It doesn't mean 20% crescents. The same is for chronicity. If I have 1 globally sclerosed glomerulus out of a biopsy with 6 glomeruli, that does not mean low rate of global glomerulosclerosis. So this is why number of glomeruli is important. This is important. And this is why we add it. So you would understand how adequate this biopsy is, and you should interpret the report according to this adequacy. ثانية واحدة بس ممكن just a second. Okay, I'm sorry. Now, the location of the biopsy makes a difference as well. So it's not only by the size. Don't get subcapsular tissue. Like you can see here, this is a subcapsular biopsy. This is a biopsy. This is the renal capsule, and this is subcapsular tissue. All of these are glomeruli. This biopsy had 10 glomeruli, which is adequate by definition, but this is an inadequate biopsy because of its site, because subcapsular tissue contains more global glomerulosclerosis and more interstitial inflammation. If you want to exclude FSGS, then try to get juxtamedullary tissue. This is preferable for focal segmental because this is where FSGS starts. So if we have corticomedullary tissue, then it's better. Size of the core, size matters. It's not only the number. This small piece of core fragment here.
نعم. وسام. يعني اللوكيشن, the best location هو ايه؟
The best location is to get a good, يعني this biopsy is taken somehow longitudinal. Sometimes بيدخلوا كده بالورب أو مش عارفة بيعملوا إيه بالظبط. And to get the whole thing. No, the best thing is to try to get the cortex plus or minus the capsule, but to get a bit deeper than the capsule. But when you only get subcapsular tissue, then this is also, again, not a good biopsy for evaluation.
تمام.
لأن هتلاقي chronic changes كتير قوي, which doesn't reflect actually what's going on in the kidney. The size of the core is important. في small cores like this core, by the way, contained 8 glomeruli. So it's not only the number. And then you come to say 8 glomeruli, كان فيها 8 glomeruli. كاتبه لنا inadequately. Inadequate because this is a very small cortical tissue. It doesn't reflect what's going on in the kidney in relation to interstitial fibrosis, whether you have inflammation or not. This is the tiny fragment. So the size of the core makes a difference because most of renal diseases are patchy. And if you need an evaluation on the total chronicity of what's going on in the kidney, then you need to get a good long core for proper evaluation. So it's not only the number, you do not only evaluate the adequacy of the specimen with the number of the glomeruli, but the size of the core also makes a difference.
عندنا رقم يا دكتور وسام؟ في
لا
رقم
بس يعني
لللينث اوف ذا
يعني
لللينث اوف ذا
yes
كور.
preferably ما يبقوش اقل من 0.8 يعني ال
تمام
0.5 وال 0.6 دول بيبقوا مأساويين الحقيقة.
تمام
فيعني 0.8 and more are usually يعني reasonable cores.
تمام.
Okay, handling the specimen. Then what you do with the core? Now we know that we have three modalities or three diagnostic modalities for renal biopsy. We have the light microscopy, we have the immunofluorescence or the immunostudies, and we have electron microscopy. Now, please, the specimen has to be fixed. You cannot send a specimen without fixation. الكلام واضح اهو. التيشو بيتحلل بيحصل له autolysis. So you cannot send a specimen in saline. And there is not a single fixative for the three modalities, unfortunately. If there was, life would have been easy. But for now, there isn't a single fixative for the three modalities. For light microscopy, you need to use a 10% neutral buffered formalin. It seems too much, 10% neutral buffered formalin. It's not much, by the way, at all. This is a very simple formula. If you don't have it, if you don't have a phosphate buffer, you can use table salt. It's present on the online everywhere. Worst case scenario, do not buffer it, but at least make it neutral. So you make it 10% formalin, because other than that, concentrated formaldehyde dries out the tissue. So avoid over fixation. For immunofluorescence, now immunofluorescence technique is only used in large centers. So if you're working in a hospital and the pathology lab has an immunofluorescence technique, then you can take the biopsy, snap it frozen, or transport it in a transport medium, which is not available here in Egypt, which is Michel's medium, and then this biopsy is transferred to the pathology lab process, which is going to take around 5 to 10 minutes max. And then in the pathology lab, they're going to process it for fluorescence. So in order to do fluorescence, you need fresh tissue, which is just frozen or kept in the proper medium. But if you don't have this, we do immunoperoxidase instead of the immunofluorescence. For immunoperoxidase, we use the same cores you used for buffered formalin. So you don't need to send us a core in saline or a core which is fresh, because this core is useless and the tissue gets autolyzed. So if you're doing immunoperoxidase, if you're sending the biopsy to a pathology lab, which is more than 20 minutes away from you, then this is an immunoperoxidase technique, and then you're going to use the 10% neutral buffered formalin. For electron microscopy, we use, sorry, this is a typo, this is not 2%, this is 4% glutaraldehyde. So glutaraldehyde is a separate fixative, and it's usually available in pathology labs which deal with renal tissue, and you should make sure that the fixative is available before you obtain the biopsy. Because sometimes, for example, we get a lot of biopsies with electron microscopy requests where they are fixed in formalin. Why is this important? For a very simple reason. Biopsies which are fixed in formaldehyde does not fit to perform electron microscopy. You cannot do EM on it, and vice versa. Biopsies which are fixed in glutaraldehyde does not give you a good quality under light microscopy. So when you do not fix properly, then you have the chance to lose both tissues. How many cores should we have? Well, ideally, you need to obtain 2 cores. You really don't have the option of this single core
دكتور وسام بعد اذن حضرتك. نعم. في اسئله جايه لي على الشات هنا بقول لك يعني ايه البرو والكونز بتاع الاميون بروكسيديز فيرسس اميون فلوريسنس.
I'll say it in 2 minutes.
طيب الحاجه الثانيه في سؤال ثاني، هل we can divide one core for light and AM؟
I'll just say it right now.
اوكي. سو يعني لو صبر اتفضل.
Okay, so ideally, as I said, we should obtain 2 cores. No, you cannot divide 1 core, because simply you should not get only 1 core. 1 core is not enough. You should always obtain 2 cores. At least when one of them turns to be medulla, you don't have to repeat the biopsy. So ideally, you obtain 2 cores. These 2 cores, if you want to do EM, then you slice it as I show you in the diagram. You take 1 micrometer square from both ends of each core, and this is the tissue which is processed for EM. We don't need more than this for EM, because for EM we use only minimal tissue. So this tissue is enough. But bear this in mind, you cannot cut the core into half and then process half of it into EM and half of it for the other techniques. Not because you cannot do this, you can do this, but this is useless, because what happens is that what we get for electron microscopy is medullary tissue. This is usually what happens, or you're going to get medulla in the light microscopy. So you cannot divide the core by half. This is planned. So in order, if this is medulla, then this will be cortex. And if this is medulla, then this is going to be cortex. So we are maximizing our chances to get an adequate biopsy. So just don't come and cut it in the middle and decide that I'm going to send half of this core for EM, half of this core for light microscopy, and then you want a diagnosis. No, this does not work. If you're going to do immunofluorescence, then you take 2/3 of the core for light microscopy and 1/3 of the other core. 1/3 and 2/3 for light microscopy. And then you take the rest for immunofluorescence. So this is how you divide your cores. How do you do that? You put the cores on a glass slide, you slightly wet them by saline, and with a very sharp blade, then you start cutting these cores. If you're using immunoperoxidase, as most of labs do here in Egypt, then you don't really need to slice it into 1/3 and 2/3, because all the rest of the material will be processed for light microscopy and immunoperoxidase. Does this answer your question?
I think it's clear now, very clear.
Okay, great.
شكرا جزيلا.
Now, this is not standardized. You need always to think, why are you taking the biopsy? This division of cores and the techniques or the amount of tissue you are contributing to each diagnostic modality depends on the disease of consideration. For example, if you're doubting that the patient is an Alport syndrome, then you don't really need the immuno. You need the electron microscopy and the light microscopy, because Alport does not have any immuno pattern. On the other hand, if you're doubting that this patient is an IgA nephropathy, then you only need the light microscopy and immunoperoxidase. And if you have only minimal tissue, then leave it for electron microscopy. You always need to think, because if you have a patient with a single kidney, if the patient is non-compliant and you are not able to get except 1 core, if it's an obese patient and you're not able to get adequate tissue, in this case, then you need to consider what are the most important diagnostic modalities you need in relation to the clinical presentation of the patient and the disease that you're considering, and you want an answer from the biopsy. So this is also very important to consider. So just not any tissue for any diagnostic modality. It doesn't go this way. You need to think, consider your patient, see the whole circumstances, evaluate the whole situation, and then decide which diagnostic modalities are going to be more valuable for you. Is it the electron or the immuno?
في سؤال هنا دكتور وسام. Is there a difference between the immune fluorescence and the immune peroxidase regarding yielded data?
Regarding?
Data yield.
Yielded that.
Yeah.
Again, this is, I'm going to come to fluorescence right now. It's more or less like the same question before.
Okay.
Okay, remember that we do not fix our tissue in saline. This is only to prevent drying during dividing the core. Please, please, please. I have been saying this for the last 15 years, and I still receive biopsies in saline for immunofluorescence. So please stop. Saline is not used to fix biopsies. Do not freeze the biopsies. If you not for formalin fixed specimens, and you can only put glutaraldehyde fixed specimens in a temperature, not freezing temperature, in a temperature between 4 and 6 degrees, just on ice. So specimens are not to be frozen, they are not to be put in the fridge. The EM biopsy needs to be cooled down, but formalin biopsies are not to be put in the fridge because this produces actually technical artifacts in the biopsy. A formalin fixed specimens, and the whole process is a heat-dependent process. When you cool it down or when you freeze the specimens, you stop the fixation process. Labeling, it's extremely important. I have just said that if you mixed up the specimens, then you lost both your cores. You're not going to have an electron microscopy study, and you're not going to have light microscopy or an immuno study. So label each vial with the name of the patient, the nature of the biopsy, and the type of test or fixative that you are using. Do not count on the other end. Do not count on the lab personnel that they are going to know or that it's going to smell different or so on. Make sure that the vials are properly labeled in order to avoid any form of confusion. For light microscopy, what we do is, I just want you to know that we don't put the specimen into a machine and that the machine gets us a piece of paper with a result at the end of the day, like in clinical pathology. We have a long process, something which is called processing. We dehydrate, we paraffinize, we embed, and so on. And this just a couple of slides for the pathologists who are with us, that embedding in light microscopy makes a difference. This is what we call a paraffin block. And you nephrologists should know that we embed, this is your core, and your core gets embedded into this rectangular piece, which is called a paraffin block. If you embed the tissue this way, this is the wrong way. The tissue has to be embedded all equal on the surface. Why? Because when you do it this way, 50% of your core is lost. All the area in the middle doesn't exist. It's not on the slide. But when you embed it this way, this is the correct way and nothing is lost. It has to be cut on a certain level. This is a thick section. Look at this glomerulus. You feel so many things are going on. This is a hypercellular glomerulus with a lot of mesangial proliferation and probably thickened glomerular basement membranes. This is the same glomerulus, by the way, and it's completely normal. This is the difference between the thickness of the section. So sections has to be cut. We really need thin sections to evaluate proper morphology, 2 to 3 microns. Regular pathology sections for cholecystectomy, appendix, breast, any other tissue are cut on 5 microns. This just to give you an idea that you cannot just send your renal biopsy to any pathology lab. If the pathology lab is not equipped to handle a renal biopsy, then you are going to get wrong diagnoses. Not because this is an unexperienced pathologist, but because also the technique is different. Renal biopsies need special handling techniques, which are only provided in labs, which are used to work up renal biopsies. The second thing is serial sections. Dr. Hussein just asked about the serial sections, and you say that you count glomeruli serial sections and so on. So in a regular pathology, again, in a regular pathology lab, what we do is 2 slides, and each slide has 2 sections. For renal biopsies, we do from 11 to 14 slides with at least 15 to 30 sections per biopsy. And these sections are stained with special, not only with hematoxylin and eosin. Why
يعني
do we need this?
حضرتك بتقطعي الكور لسكشن صغيره برضو الحته دي برضو
هو ده اللي اسمه
نفهمها.
سكشن. This is it. طبعا عايزين تفهموها. اوكي انا بمشي بسرعه قلت عشان ما تزهقوش.
لا ساعات لان ساعات بتحيرنا السكشنز وكم سكشن. يعني انت حضرتك بتاخد الكور قدامك زمان زي صابعي كده، بتمسكيه تقطعيه حتت صغيره يعني، ولا بتعمليه ازاي؟
ايوه خلينا نرجع تاني. الكور اهو اتحط، ده اسمه بلوك شمع.
تمام.
اوكي.
اوكي.
And then we put it on a microtome, this rectangular piece of paraffin wax. هو شمع فعلا.
تمام.
A special type of wax. And then this This allows us to cut these sections. الميكروتوم is a special instrument شغلتها انها تطلع الحاجات دي. بيطلع لنا a piece of wax جواها the tissue. ايوه حته من الشمع جواها الكور. بعد كده بنلقطها على السلايد الازاز والشمع بنسيحه and then we start staining the tissue. So you get a section of this tissue which is 2 millimeter thick, 3 millimeter thick, or 5 microns. This is a routine pathology work.
تمام.
Okay.
يعني لو صبع كده يا دكتور وسام بينزل عليه يقطعه كده زي ما بقطع طماطم، حتت بتنزل ترانشات صغيره.
زي البسطرمه. عارف مكنه البسطرمه في السوبر ماركت؟ بالظبط. هو بالظبط الميكروتوم زي مكنه البسطرمه بالظبط كده.
كويس، جميل.
وهي وشوف شوف البليد بيقطعه رفيع ازاي، هو نفس الفكره. فالفكره ان لازم تبقى ثين سكشنز، ودول بيحتاجوا مش اي باثولوجي تكنيشن كمان بيعرف يشتغل الكلام ده، لازم يبقى تكنيشن شاطر. وزي ما انت شايف احنا بناخد اهو كل واحد من دول اسمه سيريال. فالسلايد دي عليها 2 سيريال، فكده 1 2 3 4 5 6 7 8. you understand? So each one of this is a serial section.
كويس، جميل.
And each slide is stained with a special stain. So this is H&E, this is PES, this is trichrome, أو وده this is trichrome, and so on. ليه بنعمل كده؟ وليه بنقعد نرقمهم 1 2 3 4؟ عشان ال renal diseases are very focal and we need to get different levels of the tissue. So that's why we get so many serial sections in order to make sure that we've gone and seen all the levels of the tissue and that we have examined all the biopsy. For example, you get to see a glomerulus in slide number 1 with this structure, and you keep saying, is this a crescent or this is just epithelial hyperplasia? The only way you know is that you follow it up on your serials, and on your serials, it will eventually turn into a full-blown crescent. If you don't have enough serial sections, then you might miss it. And this also provides a problem in consultation biopsies. When you come to send a biopsy to a renal pathologist which has been already examined in a regular pathology lab because of the lack of special stains, the lack of several serials, and so on. The stains, we have standard stains in pathology: hematoxylin, eosine, silver, periodic acid shift, fibrous tissue stains like serous red and trichrome, and of course the additional stains for Congo red, for elastic stains, COSA, for calcifications, and so on. But the choice of the stains depends on the comfort of the pathologist. Some people are comfortable only with silver stains. Others work mainly with the PAS and they take a quick look at the silver. Some pathologists do not perform trichromes at all and use other stains for it. So you cannot say that you must have special stains, but the type of stain depends on the experience and what the pathologist is comfortable with. For starters, this is how H&E looks like, and hematoxylin eosine stain is only for renal pathologists, only used to evaluate whether we have cortex or medulla and if we have interstitial infiltration. Otherwise, this is a useless stain in evaluation of renal biopsy. And again, this is what you usually get in a regular pathology lab, which does not work with renal specimens. You don't get special stains. So the evaluation is on an H&E sections. So these are defaulted reports because on H&E only, you cannot evaluate a lot of things. Number 1 is the glomerular basement membranes. Glomerular basement membranes need special stains in order that we can see the glomerular basement membrane, which is in here, and evaluate its thickness or whether it has anything going in it. This is the silver stain, and it can be done with or without another stain. And as you can see, this is of course this is not my picture, this is a picture on the internet, a very known picture with the spikes on the capillary basement membranes in a membranous glomerulonephritis. And this is a normal glomerulus. And silver stains basement membranes black, and extracellular matrix also black like the mesangium. So you get a black mesangium and a black capillary basement membranes. Silver stains are a bit of a complicated and difficult techniques and expensive stains, so they are not very popular with technicians, so not every lab is capable to perform silver stains. But at least usually a single slide of a silver stain is always performed. However, the main mainstay of a renal pathologist is the periodic acid shift. You cannot work or interpret a renal biopsy without having a PAS stain. PAS is the poor man alternative for the silver stain. PAS also stains basement membranes, but it stains them purple to red, as you can see here. And it is the best stain for evaluation a lot of things. Glomerular membrane, thickening capillary wall collapse, halitosis, if you have mesangial sclerosis, if you have inflammation, and so on. As I said, this is a main stain. Then we have trichrome stain, and the trichrome stains evaluate the amount of fibrous connective tissue. We stain it green with muslin trichrome and blue with aniline blue. And this gives you an idea about interstitial edema and the extent of fibrosis. It stains fibrinoid necrosis in arteries very nicely, as you can see this. And in a very good trichrome stain and in a really good section, it can work instead of EM, and you can see it, or like IF actually. Can you see these? All of these red spots are actually deposits.
سؤالي يا دكتور وسام، سؤال صغير هنا. ليه سموه ترايكروم؟ انا اوير بس عاوز نسمعها منك. ثلاث الوان
عشان it has
اتفضل.
Yes, because the stain produces 3 colors. You get a color for the collagen and the fibrosis, and a color which is green or blue, and a color of the nuclei, which is black, and a color of changes, which is of the epithelium, which is purple. So this is the classic trichrome. And you can see here, this, as I said, are immune complex deposits. This is in lupus patient. And again, you can see the immune complex deposits. A good trichrome, actually, with the proper stain and proper sections, can work as IF. Now, you definitely know that you have immune complexes on the glomerular basement membrane. Another more or less routine stain is the Congo red stain. Now, Congo red stain is used for amyloidosis. And amyloid stains this nice orange red color with the Congo red stain. But this is not diagnostic. The diagnosis is that it gives you the apple green birefringence under polarization light. So if the biopsy is not polarized, this is not diagnostic for amyloidosis. It doesn't make a difference if it gives you this color or not, because collagen also stains the same color like amyloid in Congo red sections. So the diagnosis of amyloidosis is only if it gives you this apple green birefringence under polarization. Although we've been saying that it's very important to have thin sections all the way, but for Congo red sections, we utilize a bit of thick sections in order to better visualize the amyloidosis. So if you are in a starting lab or a young pathologist, you're not really still accustomed to Congo red, cut the Congo red sections on 5 microns, and it will help you to visualize the amyloidosis and the apple green birefringence much easier than the thin sections of the biopsy. Okay, now that what everybody...
وسام لحظة. بالنسبة للكونجو ريد، how frequent حضرتك بتعمليه؟ وهل بتعمليه حضرتك لما تلاقي فيه lesion suggestive of amyloid ولا بتستخدميه يعني
روتين؟
حضرتك بتستخدميه.
هو انا
اتفضل.
هو زمان الحقيقه كنا بنعمله only upon suspicion.
تمام.
يعني if I suspected, but for يعني تقريبا اكتر من سنتين دلوقتي we do it routine on all native biopsies.
جميل. كانوا طلعوا اشاعه كده يا جماعه الانجليز من كام سنه انه كارسينوجينيك. الكلام ده اعتقد طلع فيكشن، مش كده؟ طلع اكذوبه.
هو طبعا هو يعني مش قادره اقول لك اكذوبه ولا مش اكذوبه، بس هو الحقيقه يعني اكيد مش كارسينوجينيك اكتر من الفورمالين. هو هي دي يعني احنا شغل معظم الكيميكالز بتاعتنا للاسف از كارسينوجينيك، بس لا الكونجو ريد بير سي از نوت. وبعدين اصل يعني التكنيشنز بيلبسوا
احنا لما اشتغلنا في الجوده شويه كنا اشتغلنا في معمل الباثولوجي، فاوير بان ان المفروض ان في رولز للسيفتي should be followed في الباثولوجي لاب.
very
فده
strict rules.
المفروض تبقى very strict، والا يحصل مشاكل.
لان الباثولوجي لابز مأساويه. ده حقيقي. احنا عندنا الماتيريالز كتير كارسينوجينيك، وبعدين للاسف مثلا في معامل بتستعمل ميثايل الكحول بدل ايثايل الكحول، والميثايل بيعمل بلايندنس وبيبوظ اللنج بتاعت الناس عشان اتس ماتش تشيبر. فلا يعني الكواليتي
لا، ما هو ده
كنترول
نقطه
في المعامل
بناخدها علشان احنا معانا 92 دكتور معانا على الهواء دلوقتي، واللي هيسمعوا الفيديو بعد كده ان شاء الله. احنا المفروض نتبع السيفتي، لانه زي ما بنقول الستاندرد اوف كير حتى في اعطاء دواء، نعرف الدواء ده ايه اللي له وايه اللي عليه. احنا مثلا السايكلوفوسفامايد لما الناس بتيجي تديه مكتوب في البريكوشنز ان انا ابقى لابس جون معين واحمال العين والكلام ده. نادرا ما تلقى الاطباء بيلتزموا بالسكيورتي والسيفتي المكتوبه. فحتى لو هي رير اوكرنس لابد نحتاط من الكلام ده ونتبع الرولز، لان السيفتي مش معموله من فراغ.
ده حقيقي. وحتى احنا عندنا التكنيشنز، بس الحقيقه الجنريشنز يعني when you insist they do. يعني I have to insist ان هم they wear gloves و they wear white coats and so on. otherwise هتلاقي الدنيا يعني تمام. بس عامه الماتيريالز ما بتبقاش كارسينوجينيك اكسبت كمان upon heating. يعني هو ده اللي هيعمل لهم ماكسيمم اكسبوجر، وده ما بيحصلش في حاجه زي كونجو ريد ستين.
لكن اللي حضرتك وضحتيه النهارده ان حضرتك بتعملي في كل العينات بتاعتك كونجريد
روتين في النيتف we don't do it routine في الترانسبلانت. we do it routine في النيتف. yes now it's a routine procedure. لان لما الدنيا اتغيرت وبقينا عارفين ان في انواع اميليدوزس ثانيه، وبقينا نعرف more about the disease وان هو في minimal deposits، بقى موضوع ان انا اعتمد بس على عينيا our own clinical suspicion is not a practical thing. فبالتالي لا now we do it routine. اوكي.
السؤال الاخير في النقطه، معلش انا بقاطع لانه الناس
ما فيش مشكله خالص.
لا عشان نفهم، لان دي فرصه ذهبيه. يعني دلوقتي ان انا ساعات بيبقى الاف اس جي اس او السكليروتيك ليجنز، ساعات بيبقى في بعض السيميلاريتي، ولا حضرتك بتقدر تحلفي ان ده ستراكشر ليس ليجن موجود؟ مش ساعات بيبقى في حاجات كده باينه ولا ايه؟
بس ده في الريجولار سكشنز. ما هي دي ميزه انك تعمل روتين كونجو ريد.
تمام. ما ده اللي انا
اولا في الاتش ان اي،
ده اللي انا بقصده من الروتين نيد اوف كونجو ريد.
في الروتين في الاتش ان اي it's almost impossible. يعني needs a very experienced pathologist. البي اس ممكن تلقطه بس برضو مش دايما سهل وممكن يعدي. فهي دي الحقيقه الادفانتج of doing a routine Congo Red. then you can pick up what you can miss.
تمام، جميل.
طبعا ده بيفرق جامد. واحنا ان شاء الله when we come to talk about amyloidosis we will discuss all of these things in detail. اوكي. immunopathology كله قاعد يسال على الاميونو من اول ما ابتدينا. طيب immuno studies are essential in kidney biopsy examination and I will put 10 lines underlying the word essential because it's very important for diagnosis. It distinguishes between immune and non-immune pathogenesis, and this is what would give you your guideline for treatment and management of the patient. Without it, we cannot segregate different pathologies بدون نفس histological patterns, as we are going to discuss in few minutes. Some diseases are only diagnosed by immuno. ملوش أي معنى إنك تبعت request for light microscopy وتكتب عليه query IgA nephropathy. How are we going to diagnose this? IgA nephropathy is an immunodiagnosis. This is a diagnosis based on immuno studies. So this is not going to be diagnosed. Same for light chain disease. Again, this is an immunodiagnosis. C3 glomerulitis, an immunodiagnosis, and so on. And it is the most important complementary method to evaluation of kidney biopsies, especially if we are considering glomerular disease. Okay, we have two modalities, immunofluorescence and immunoperoxidase. On the right, this is how immunofluorescence looks like. It's fluorescence because the positive gives you this nice green fluorescence color against a black, dark background. If it is not positive, it will be difficult to evaluate the structures and know whether this is a proximal or distal tubule. and whether this is really a glomerulus or a blood vessel. On the other hand, on the this is on the left. On the right side, you have this is the immunoperoxidase, and immunoperoxidase stains brown. So the positive is brown. So you have here a nice brown staining on the glomerular basement membrane. Immunoperoxidase, because this is a paraffin embedded section, and now you all know what do we mean by a paraffin embedded section. So you can see that you can see the details. So you can see the basement, the tubules, you know, this is a distal tubule, you know, this is a proximal tubule, you can see the mesangium, and so on. So this is fluorescence, and this is peroxidase. Both antibodies, we have antibodies which work for both modalities. So whether we're using fluorescence or peroxidase, you can stain for IgA, IgG, IgM, C3, C4, C1q, fibrinogen, kappa and lambda, C4D, viruses in transplants, antiphospholipase, thrombospondine, and so on. Actually, most of the new antibodies are based on immunoperoxidase stainings, not on immunofluorescence. So phospholipase is much more widely used by immunoperoxidase technique than the immunofluorescence technique. For example, polyoma. The polyoma virus is basically an immunoperoxidase technique. I don't think there is no immunofluorescence technique for it. It's only by immunoperoxidase. So you can only stain for polyoma virus or BK viruses by immunoperoxidase. Same is for CMV. Also, you can only stain for it by immunoperoxidase. You don't have a fluorescence antibody for it. This is a very expensive and long panel of antibodies. And cost is a very important issue, not only in our country, everywhere in the world. Cost is always an important issue. Do we have to do all of this? No, we don't have to do all of this. What we really have to do is for a native biopsy, we need to do IgA, IgG, and C3, full stop. You can easily give up the IgM, and you don't really need the C4, nor the C1q, nor the fibrinogen.
بس الكابا واللامدا دكتور وسام الكابا
I
واللامدا.
was just gonna say, yes, kappa and lambda depends on the age of the patient. So with a more increased, or if you have a suspicion in the biopsy, if this is a mid-30 patient with a suspicious lesion for kappa and lambda, then go ahead, and then we're going to use kappa and lambda. But kappa and lambda should be done routinely for patients over 50 years old. They should be a routine stain requested with the panel over 50-year-old of patients. My point is, Dr. Hussein, is that cost should not make us stop for ordering immunoperoxidase or immunofluorescence techniques on the renal biopsy because we say it's too expensive. This is what I'm trying to explain, that costs can be modulated. We can use the minimally necessary antibodies. If you're working in a place, there are still some cities with no pathology lab, and if you want to start a renal pathology service, or if you're joining us from, you know that you can start a basic renal pathology service with just these few antibodies. C4D, of course, for transplant, and we're going to discuss it when we come to transplant pathology. But then you have other important markers which you really need for diagnosis. And some of them
في سؤال لحضرتك هنا يا دكتور وسام على الشات. في حد بيتكلم على IgM is it necessary في الاف اس جي اس؟ So should I stain IgM؟ انا بتهيألي لا، لانه انا يعني كان عندي معلومه وحضرتك صححها لي انه الاي جي ام اي سكليروتيك ليجن الاي جي ام باي ستاندر هيبقى موجود. ده كلام صحيح ولا غلط؟
لا صحيح مظبوط very true. الاي جي ام is a macroglobulin. جلوبولين كبير قوي كده
900,000 الوزن بتاعه.
بالظبط. And it tends to be trapped in a lot of things. مش بس في السكليروسس. It's trapped in the necrosis, it's trapped within the thrombi, and that's why we have a tendency to give it up. يعني it's not such an important antibody for us because it has a lot of non-specific pattern.
انا بفتكر وقت كلام الدكتور هيلموت رينكي لما كنت معاه في هارفارد، كان بيقول الاي جي ام نفروباثي ده ممكن يكون يعني اوفر دوينج الضاف كترمينولوجي. he doesn't believe in IgM nephropathy كترم باثولوجي يعني.
Neither do I. neither do I. I don't believe there is a disease called IgM nephropathy اصلا.
تمام.
and I don't think انتوا عندكم في ال nephrology literature حاجه اسمها IgM nephropathy with management guidelines.
كتبت، هو قال ان حد كتبها في التكست والناس مشت ورا التكست وخلاص، لكن ليس لها وجود، وان الاي جي ام ده
هو كمان الفكره ان احنا يعني برضه we need to know عشان ما نظلمش حد ان احنا we are a rapidly evolving field.
تمام.
ان احنا اتغيرنا the last 10 years، غيرت حاجات كتير قوي في مفهومنا والكونسبتس بتاعتنا regarding glomerular injury. We have to know this. So what we used to know.
فعلا كلام حضرتك صحيح، لان
بالزبط.
الواحد مثلا بيشوف المجلات في خلال 3-4 سنين اللي فاتوا دولت، ما اظنش ان في ريت مقاله اي جي ام نفروباثي، فهو اختفى تقريبا. لكن هو
أيوة،
من ايامها قال لي حد كتبها في التكست، وان التكست ده واحد من البور ريسورسز، وساعات حد بيكتبها والناس يقولوا ده خلاص الراجل ده بدل قال كده تمشي الامور، وساعات بقى الكلام ده مش اكوريت.
لا الكلام ده مش مظبوط، وزي ما حضرتك بتقول اكتر من 3-4 سنين في حاجات بتتوصف، ومش عارفه ليه دايما الحاجات اللي مش اكيوريت واللي بتتغير هي اللي بتفضل لازقه في دماغ الناس. يعني مش عارفه ليه، يعني دايما بننقي الحاجات
عامله زي اللغه العربيه خطا مشهور او خطا شائع.
ايوه بالظبط كده، ده حقيقي. فهي دي المشكله that we have. that's not specific trapping. ولما نيجي ان شاء الله الاسبوع الجاي نتكلم على الاف اس جي اس، هنريمارك على بالذات قصه الاي جي ام and C3 staining in FSGS. The last point here لما نقارن بين both techniques، عشان عارفه انتوا السؤال ده زنقكم، ان there are other markers which you should use and utilize، لان الماركرز دي are commercially available وموجودين في الماركت، لان دول هيوفروا عليكم كتير قوي ان انت تقعد تعمل a lot of screening and a lot of serology markers for the patient. If it's available and it's under your hand then you should use it. زي الماركرز بتاعت الممبرينز، زي الانتي فوسفولايبيز، زي ثرومبوسبوندين. لو البيوبسي inadequate، لو البيوبسي globally sclerosed، او لو انت بتعمل الفوسفولايبيز pre the biopsy، this is a different story or follow up. بس بنتكلم at the time of diagnosis then you do have other techniques which you should use، لأن this gives you a diagnosis. دي كانت حاجة ما كانتش available عندنا من 4-5 سنين فاتوا، إن أنت تطلع ب diagnosis, a final diagnosis upon which you can start managing your patient the second day. Again, immunophenotyping of amyloidosis and different amyloid proteins, IgG subclasses عشان monoclonal IgGs and so on. So بس to give you an idea, and these are the commonest antibodies that we use in relation to renal tissue. What are underlined are the most important ones. The ones in red are the additional important markers you should always ask for if they are available or not, or try to find them. And that all of these markers are available by both modalities, whether fluorescence or peroxidase. اوكي.
الثرومبوسبوندين ده موجود يا دكتوره وسام؟ الثرومبوسبوندين بقى افيلبل؟ بقى كوميرشال افيلبل؟
من زمان. بقى له سنه.
ما هو الثاني بقى له 11 سنه تقريبا دلوقتي، الانتفوسولايبيز ايزو، لكن ده كان لغايه فتره قريبه كان مش كوميرشال افيلبل. احنا عند حضرتك
لا
موجود في
عندي
طب كويس.
عندي وبيتعمل من من احسن المارك في كذا شركه بتعمله، ابكام وسيجما اولدريتش وموجود. فعندي احنا عندنا انتي فوسفولايبيز وثرومبوسبوندين.
في واحد كاتب سؤال، which microscope to be used، راح فين السؤال في على الشات، راح فين؟ which microscope used for Immunopathology؟
هرد حالا. بيصبروا بس مش مديني فرصه.
ما احنا بنتفاعل بس معاك عشان نريحك شويه. اتفضلي.
طيب اوكي تمام. زي ما قلت الفلوريسنس بيتعمل على فروزن تيشو، البيروكسيديز بيتعمل على فورمالين فيكست تيشو. طبعا الفريش تيشو الانتيجينز بتبقى لسه فريش وانت ما لعبتش فيها، لان they are not formalin fixed. So immunofluorescence gives you high sensitivity. It's a much easier technique and quicker. التكنيك نفسه is simple. and can detect any antigens. ما بيديش باك جراوند جامده في السلايد and it's faster. اسرع كتير. you can have an immunofluorescence او يعني كان اسرع قبل ما يبقى في اوتوماتيك ستينرز للباراكسيديز. دلوقتي الاثنين بيطلعوا في نفس الوقت. however الفلوريسنس عايز بيدي بور مورفولوجي، بور باك جراوند مورفولوجي، بتبقى دايما مش عارف انت فين بالظبط. الفريز requires freezing، ما بيديكش permanent sections. السكشنز بتاعت الاميونوفلوريسنس دي بتروح بعد 14 سنه، يعني ما ينفعش ترجع لبيوبسي اتعملت اميونوفلوريسنس من سنتين وتقول انا اصل انا عايز ارجع اتاكد من الاي جي جي بتاعها. مفيش كده. هي بعد اسبوعين it fades away and it needs special microscopes and special rooms. بتحتاج dark field to be examined، وعايز مايكروسكوب مخصوص، عايز جهاز مخصوص يبقى موجود في المعمل اسمه كرايستات عشان يقدر يقطع frozen tissue، عشان ده بيشتغل under freezing. So it's costly و it's a bit يعني sophisticated technique. On the other hand بقى الباراكسيديز بيشتغل على fixed paraffin tissue، فبيديك good morphology وبيدي permanent sections. بعد 3-4 سنين you can still look at the IgG slide وتقول اذا كانت positive ولا negative عادي. مش محتاج اي special equipment. الباراكسيديز بيتبص عليه، بتقدر تشتغل عليه ريتروسبكتيف. ممكن تيجي تقول لي انا كان عندي عينه من عيان واخدها من سنتين وعايز اعمل عليها اميونو، ونقطع منه سيريال سكشنز ونعمل عليها باراكسيديز، فتقدر تشتغل ريتروسبكتيف ستاديز زي ما انت عايز. However, peroxidase is 30% less sensitive than fluorescence، وده result of the formalin، عشان الفورمالين بيكواجوليت the proteins، واحنا عارفين كده، فبنعمل حسابنا في الانتربريتيشن بتاع الباراكسيديز that to compensate for this 30% lower sensitivity than fluorescence. هو difficult technique، لا ملو يعني معلش الكلام ده قديم شويه. limited number of antigens الكلام ده اتغير ويوجوالي ليه هاي باك جراوند. الحقيقه ان احنا من 5 سنين ظهرت حاجه اسمها اوتوماتيك اميونوستينرز، والاوتوماتيك اميونوستينرز عملوا ريفولوشن في الاميونوباراكسيديز، في السنسيتيفيتي، في الكواليتي بتاعت التكنيك، في النمبر اوف ذا انتي بوديز، وفي السبيد. فيو ستيل جيت ان اميونوباراكسيديز سلايد زي الاميونوفلوريسنس بعد 3 ساعات من يعني من اول البروسيس. وده كمان خلى الشركات بتاعت الانتي بوديز تتشجع وتطلع كل the whole range of antibodies for paراكسيديز. بالعكس ابتدى الفلوريسنس يرجع ورا شويه. هو طبعا it's the gold standard ان if I have access for fluorescence طبعا why not، ولو عندي الماتيريال and so on. بس احنا بنتكلم على what is available، وبنتكلم ان دلوقتي ما فيش معمل في العالم بيشتغل رينال باثولوجي بيشتغل اميونوفلوريسنس روتين الا لازم يكون عنده اميونوباراكسيديز. اولا بقى في ماركرز افيلبل باراكسيديز بس مش فلوريسنس، يعني بقى دي other way round. دي اول حاجه. تاني حاجه لما الكور بتاع الفلوريسنس او البيسز اوف ذا كور بتاعت الفلوريسنس بتطلع فيلد او تطلع مضله، هو محتاج يرجع لللايت مايكروسكوبي، فالباراكسيديز is a good option بالنسبه له and so on. So immunoperoxidase is getting to be more widely prevalent, and يعني in a country like ours it is the more suitable technique. بس هو it's more expensive عن الفلوريسنس الحقيقة as maintenance wise. Does this answer your questions regarding الفرق بين الفلوريسنس والباراكسيديز؟
في سؤالين هنا يا دكتور وسام.
اتفضل.
اللينير والجرانيولار واحد كاتبهم، يعني ايه الفرق؟ هل
هقوله حالا.
والسؤال الثاني اللي
هم
جاي
70 دايما 70.
والسؤال اللي اتقال حضرتك بتقول لي احنا بنكمبنسيت 30% لور سنسيتيفيتي، بنعمل كومبنسيشن. ففي سؤال جاي بتكمبنسيت ازاي؟ الناس صح معاك يا دكتور؟
قوي قوي مركزين قوي.
ده جميل.
بنعمله باي ذا انتربريتيشن، وان شاء الله هو لو فضل معايا لحد لما ندي لما نوصل للترانسبلانت وندي السي 4 دي I'll give you a very يعني clear example how we compensate this by our interpretation. بما معنى ان انا ببقى عارفه امتى possibility ان انا عندي weak staining وامتى اقول عليه strong intensity وامتى اقدر اقول عليه positive or negative. This needs experience طبعا، بس دايما في الباك جراوند ان this is fixed tissue، وان التيشو ممكن يجي over fixed وممكن يجي under fixed، وان ممكن يكون عندنا problems في الفيكسيشن. هو ده اللي انا قصدي عليه ان احنا بيكمبنسيت، قصدي ان احنا بنبقى عاملين حسابنا in the interpretation of the immunoperoxidase the quality of the specimen you're dealing with. But I'll show you in something like the C4D scoring how we actually do compensate for this 30% difference. This is linear and this is granular. So this is linear and this is granular on the basement membrane. Now this pattern is for immunofluorescence. Okay? So if you're doing immunoperoxidase, don't ask for a linear and a granular pattern.
إجابة واضحة.
اوكي؟
تمام.
إجابة واضحة جدا. تمام؟ اللينير والجرانيولر دول اتوصفوا بيست على الفلوريسنس تكنيكس. الناس اللي بتقرا من كتب، كل اللي مكتوب في الكتب وفي التكست بوكس بيست على الفلوريسنس تكنيك. ده مش ابليكابل على الباروكسيديز.
ده الباروكسيديز بوزيتيف ونيجاتيف.
بالظبط كده. However, let me surprise you ان احنا وده برضه بنكومنت على الكومبوزيشن والانتنسيتي والسايت، بنقعد نقول والديستريبيوشن وموجود فين كل الكلام ده. بس let me surprise you how advanced the peroxidase بقى. Can you see the granularity on the
واضحة
membrane?
جدا.
Yes. So actually in some diseases we can get in a very good immunoperoxidase sections. زي ما بقول لك immunoperoxidase تحسن جدا. You can get, you can actually see the antibodies, see where they are, whether they are subepithelial and subendothelial, and you can see the granularity. And look here in the mesangium. Very nice immunoperoxidase staining in the mesangium. And this is on the glomerular basement membranes and in the mesangium. But you do not always get this granular pattern. يعني to answer your question, موضوع linear pattern بتاع الانتي جي بي ام cannot be evaluated on immunoperoxidase sections. Full stop. So this is the answer. Okay? So anti-GBM on tissue is only an immunofluorescence diagnosis. Okay. Now we come to the third modality, electron microscopy. Now, nephropathology is the only anatomic pathology subspecialty that uses electron microscopy for routine evaluation of specimens. الجملة دي مهمة قوي علشان nephrologists مش aware ان الاي ام ده حاجة مش widely available، وانه مش وايه ده، وبيبعتوا requests for renal biopsies مكتوب عليها اي ام for private labs. يعني كده يعني ساعات بحس ان هم شويه في اللالا لاند، فهم لازم يعرفوا ان electron microscopy is a very 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 expensive piece of equipment. يعني هو وصل ثمنه دلوقتي ل 15 مليون. Without its supporting unit it needs a big place، بيتحط in a room، ما هوش مايكروسكوب بيتحط على مكتب. And it needs a special unit with special technicians and so on. So this is a modality, diagnostic modality, which is present in institutions and in big hospitals and in universities and so on. And it's mainly a research modality. The only branch in medicine which uses EM for diagnosis هو renal pathology. An electron microscopy allow detailed evaluation of the cellular or extracellular contents بتاعت كل حاجة، glomerular compartment, assessment of the thickness contour integrity of the GBM mesangial matrix. بيوريك abnormal deposits such as electron dense immune complex deposits or fibrillary amyloid deposits. بيوريك abnormalities in cells can be readily detected زي effacement of podocyte food processes في البروتينوريا or swelling of the endothelial cells etc. etc. ده شكل الماتيريال بتاع الالكترون مايكروسكوبي والمصدر. The tissue, as I said, is cut into cubes of 1 millimeter cube and embedded in resin. Then you do resin. فده شكل البلوك بتاع الالكترون مايكروسكوبي. هو ده اللي بنقول عليه semi thin section أو thick section بتاع EM. وده بنشوفه الأول under light microscopy وبيبقى stained only by toluidine blue, this blue stain. And it tells us that we have glomeruli in this and this is actually the size of the tissue that we process for EM. وout of this we pick only one glomerulus ودي بتبقى examined by electron microscopy, and it's stained by uranyl acetate and lead citrate اللي هم بيدونا black and white. عشان كده you don't really need a full core for EM because it's really a huge waste of tissue. You only examine at the end of the day one glomerulus. طيب, we have usually a problem in with young nephrologists and emerging nephrologists that when they read in the texts, every time a renal biopsy comes up, it comes up with light microscopy, immunofluorescence, and electron microscopy. Of course, nobody can argue that EM is a very valuable tool for renal biopsy evaluation, but it's not a must. It's not a must. Again, we have moved from an era years ago where diagnoses were dependent on EM to an era where our diagnoses are independent from electron microscopy. So in this study by Mark Haas, this is one of very known renal pathologists, and this is a study of 233 native renal biopsies. EM was critical or important for diagnosis in 21% of cases. It gave an important contribution to the diagnosis in another 21% of cases. Up to 60% of cases, you did not need EM for diagnosis. So the lack of electron microscopy should not stop you from biopsying your patient. Because I hear this sentence sometimes, oh, there is no electron microscopy, then why should I do renal biopsy? No. You do renal biopsy, 60% you're going to get a diagnosis only by light microscopy. And if you do diagnosis, it's going to increase up to 80%. And you really need electron microscopy in 20%. Let's see, what are the diseases where you really need electron microscopy for diagnosis? Podocytopathies, minimal change disease, and FSGS. Then we have hereditary diseases, as Fabry, thin basement membrane output, organized deposits. And I will remove fibrillary because now we diagnose it by immuno. So, and we're going to say this when we come to fibrillary. So now we don't diagnose fibrillary anymore by electron microscopy. We have a very unique, highly specific, and highly sensitive marker for fibrillary glomerulonephritis now. And other special, very rare forms of glomerular disease, fibronectin, collagenofibrotic glomerulopathy. Seriously, apart from the podocytopathies, what's the percentage of these diseases that you really need electron microscopy for their diagnoses? Alport might be a bit common. Other than that, that's it. Other than this, electron microscopy is a confirmatory diagnosis. This is all. And it has shortcomings. Focal lesions can be missed. You don't know the composition of deposits. There is absolutely no meaning that we do electron microscopy and we see that we have mesangial deposits when we don't have immuno and we don't know what type of mesangial deposits these are. And I don't need EM to tell me that these are mesangial deposits. I'm going to see them on my immuno section with the added information that I know that these are IgA or IgG or C3, as I have shown you in the immuno pictures. Some diseases actually have no specific ultrastructural changes, by the way. Not every disease has a picture which is reflected on electron microscopy. So if you have EM, this is great. If we can do EM, this is great. We actually encourage that within every renal biopsy procedure, you should have a biopsy for a core for EM or the slices of the cores for EM, and then this gets processed and just stored as the resin block. We get up to this stage. If we need to progress for electron microscopy, if not, then this is going to stay. الصوت في مشكلة؟
لا الجملة الأخيرة تاني.
احنا for the sake of not repeating the biopsy and doing the best for the patients. في نفس الوقت بنحاول نبقى cost effective لأن electron microscopy studies are expensive. So what we do is that we encourage that you take a piece of the core for electron microscopy and we process it. بنوصله بس لحد الريزن block. And this is not expensive. And then we examine if the patient is diagnosed on the base of light microscopy and immunofluorescence, then well and good. لو membranous مثلا خلاص membranous. If the patient needs the electron microscopy, then we progress for the electron microscopy and exactly. So we don't need to go back and we have to repeat the biopsy, which is unethical actually. Okay? So this is يعني مثلا in Italy, this is the way they proceed with the renal biopsies and in Spain as well. يعني انا بس عايزه اقول لكم ان احنا مش بنقعد نقول ان الالكترون مايكروسكوبي مش مهم قوي وان اتس كونفيرماتوري تكنيك عشان يقول لك اصلهم عشان ما عندهمش واصلهم عشان ما بيعرفوش يشوفوه. على فكره لا خالص. يعني لو انتوا رحتوا انجلترا
انا فاكر
هتلاقوا الكلام ده.
فاكر في 2009 كان عندنا استاذه من فرنسا، ما كانش في اي ام في التوقيت ده في فرنسا.
يس في باريس. على فكره الاستاذه دي بتشتغل في ناكر هوسبيتال هيلين. اي نو هيلين. ما بيعملوش الكترون مايكروسكوبي. ايان روبرتس في اوكسفورد ما بيعملش الكترون مايكروسكوبي، بيعملوا 20%
لكن على الجانب
بس.
الاخر، على الجانب الاخر في انستتيوشنز فيها ده روتين حتى في كل
الامريكان. الامريكان It's an American based strategy. يعني الاميونوفلوريسنس والالكترون مايكروسكوبي روتين ده American based. لكن it's not European لان it's not cost effective وبرضه هاي كوست والمينتنس بتاع الالكترون مايكروسكوب صعب قوي. فبيعملوه برضه تقريبا نفس البرسنتج زينا، يعني من 20 ل 30% of their biopsies. لو بس في سنتر مثلا يعني لما انت حضرت معانا اسمها ايه نسيت كاندس في الامبيريال هوسبيتال في لندن بيعملوا روتين عندهم a very good EM unit. So it depends upon the service.
عندنا من انجلترا من شيفيلد اهوت محمد الحديدي بيقول بيتعمل هناك روتين.
ما انا بقول it depends on the service. It depends on the service and مكان. If you have a good electron microscopy unit with workable with a good microscope then it's great. احنا في
الصوت فيه مشكله.
في امستردام كنا بنعمل روتين. في امستردام في هولندا برضو بيعملوا روتين.
تمام.
فهو بيعتمد على على الات.
تمام.
ده بس اكزامبل لمنظر الحاجات الديagnostic are diagnosed by electron microscopy. This is Alport's basement membrane, the thin glomerular basement membrane, dense disease, fibrillary زي ما قلت dense deposit disease والfibrillary خلاص دلوقتي we diagnosed them by immuno. ده منظر immunotactoid and so on. This is just to give you an example. وده بس ده منظر اللي احنا بنقول عليه electron dense deposits. هم دول السب epithelial ودول السب endothelial deposits. At the end, the target is the highest possible quality which we can obtain. High diagnostic expertise and low technical quality هيديك overall diagnostic result medium. ولو high technical quality and low diagnostic expertise برضو overall diagnostic result is medium. لكن high diagnostic expertise and high technical quality هذه اللي ممكن تديك an excellent result. So this is what we all يعني try to get, that we get the highest possible quality. Then comes the most important part, which is interpretation. So now we have the biopsy, we process the biopsy, we cut the biopsy, we stained the biopsy, we did the immuno, we did the EM, and then now the biopsy is ready for the pathologist to interpret it.
قبل الانتربريتيشن يا دكتور وسام كان في سؤال لو عندي سكلوروزد جلوميرولوس هعمل لها اميون فلوريسنس او اميون بروكسيديز ولا نو؟ طبعا نو. ما نعولش على الجلوبال سكلوروزد جلوميرولوس ان انا هلاقي منها ييلدنج داتا، مش كده؟
طبعا خالص.
وكان في سؤال على الالكترون ميكروسكوب في الترانسبلانتيشن، احنا ما بنطلبوش لما يكون الاوريجينال كيدني ديزيز جلوميرولوباثي وعشان الريكارنس
لو شاكين في الريكارنت كيدني ديزيز.
لكن لو انا عندي رفاهيه وعندي ده روتين، كل الليت بايوبسيز بعد سنه بيتعمل لها. لكن ما دام ما عندناش يبقى
بالذات في الهاي ريسك بيشنت.
بالظبط، بنريزيرف ات للناس اللي هم عاوزين نشخص اف جي اس ريكارنت ايرلي، ريكارنت اف جي اس. غير كده عشان الكوست
هو ده اللي احنا بنحاول نقوله، ان في diagnostic modalities which are considered شويه luxurious. والله لو عندنا، يعني احنا لو عندنا the option and the money for example في الترانسبلانت ان انا اعمل للعيان DSA كل شهر I will do it، وانا هقول لا؟ وانا هعمل فيرولوجي PCR وانا هقول لا؟ بس
لا، ما هو الكوست البرايس او زي ما بنقول في الادويه وفي المعامل وفي الاشعاعات، البرايس one of the pillars.
ده مش عيب.
one of the pillars اللي بتبان عليها decision making. ما فيش كلام. لكن لما بكون انا محتاجه، والكلام اللي حضرتك قلتيه انا بحط تحته بقى مش 10 خطوط، 100 خط. لما باخد حته واحطها اللي هي البروس الاولانيه ديت بحيث يبقى عندي سمول سبيسمن فور اي ام لو احتاجته، ده في يعني ده شيء كويس.
بالظبط، ما هو ده اللي انا بقوله. يعني احنا بنحاول نعمل يعني the best we can with the least costly methods.
تمام.
اوكي.
بس
لكن مش المفروض ان هيبقى في حاجه بتوقفنا مادام it's not a main pillar for the diagnosis.
جميل.
اهم حاجه ان احنا نبقى aware ان the same pathologist interprets the result obtained by the three techniques. بلاش الهابت بتاعت ان انا اخد 2 كورس وابعت كور لباثولوجيست وكور لباثولوجيست تاني، او ان انا ابعت الالكترون مايكروسكوبي في حته وابعت اللايت مايكروسكوبي والاميونو في حته تانيه. Why? Because you have to understand that we do not diagnose by immunofluorescence ولا electron microscopy. على فكره احنا بنشخص باللايت مايكروسكوبي. This is very important. You have to understand
that. انا باكد على كلام حضرتك بتقوليه ده، لانه الدكتور الباثولوجي اللي قرا اللايت مايكروسكوب ساعات بيبقى جواه بعض الكويرز، عاوز يتاكد من بعض الاشياء، لكن مش الجروس دايجنوسيس، هو عاوز يتاكد من حاجه. فهو اقدر واحد يبقى هيجيب لي نتائج محترمه من الالكترون مايكروسكوب
ومن الاميونو. يعني انا I always tell my fellows، يعني I always tell my fellows واللي بيترين if you don't have a differential diagnosis in your mind you are not going to be able to interpret the immuno properly.
تمام.
احنا diagnose by light microscopy and I put a differential diagnosis if I need the immuno. So the immuno and the electron microscopy are ancillary techniques to the light microscopy. عشان برضو we get this a lot يا دكتور حسين. بيتبعت a biopsy for light microscopy immuno and electron microscopy. تقوم تطلع البيوبسي بتاعت اللايت مايكروسكوبي inadequate. يوم النفرولوجيست يقول لك خلاص هنستنى عينة الاي ام. مفيش حاجه اسمها كده.
fragmented care.
مفيش حاجه اسمها كده. ما ينفعش تستنى عينه الاي ام لان ما حدش هيقدر يعمل لك دايجنوسيس على الاي ام، واي دايجنوسيس على الاي ام هيبقى دايجنوسيس منقوص، يبقى دايجنوسيس ناقص، لان الكترون مايكروسكوبي مش شغلته ان هو يديك دايجنوسيس، شغلته ان تكونفيرم او يساعدك في الدايجنوسيس.
الا الاماكن اللي هي ويل استابل اللي عندها التكنيكس كلها موجوده. يعني الراجل كان في هارفارد كان يقرا لايت مايكروسكوب في يوم وثالث يوم ولا رابع يوم الفاينل ريبورت بالاي ام موجود، ولا في الخيال.
لا حاجة موجودة. انا مش ايوه لا انا مش قصدي كده. انا قصدي لما تبقى عينه اللايت مايكروسكوبي رينال مضله يقول لك خلاص هنستنى عينه الالكترون مايكروسكوبي يمكن يطلع فيها كورتكس.
لا
هو ده اللي انا بقوله، هو ده اللي انا بتكلم فيه. ايوه يقول لك لا خلاص طب احنا هنستنى بقى عينه الاي ام يطلع فيها كورتكس. يا جماعه ما حتى لو طلع فيها كورتكس احنا مش هنشخص لكم. بالظبط لان it's a small biopsy. So this is yes. So you need to understand that diagnosis is based on light microscopy and built on by the immuno and the electron microscopy. Except if it's really a lesion which needs EM وساعتها الباثولوجيست tells you يعني we cannot get a diagnosis, we need to do electron microscopy studies.
انا تاني وثالث الجزء الصغير اللي بناخده ده ده شيء حيوي جدا يعني انا
بالظبط.
من الحاجات المهمه قوي اللي حضرتك قلتها النهارده. طبعا كل الكلام مهم بس ده يعني فعلا ده في الكوست وايز
هو مش كوستي خالص
والايكونوميك.
التمرير. يعني التمرير بيكمبرايز 20% من التوتال كوست بتاع الالكترون مايكروسكوبي،
تمام.
فمش قصه خالص. it can be done. وكمان يعني حقيقه في الاماكن الكبيره والبروفايد ماتيريال فور ريسيرش والتعليم and so on. فانا بشوفها is a very useful يعني something to do.
جميل.
وطبعا بيسيف العيان كتير. يعني كفايه ان انا مش هقول له تعالى خد لك بايوبسي تاني.
كويس. ده طبعا كلام كله مهم. اتفضل يا باشا.
تمام. اللي لازم you know that we don't interpretation of renal biopsies is not alone. يعني the first ever classification of glomerular diseases was actually a conjoint effort between nephrologists and pathologists. Can Falhart, a clinician, and Theodore Farr, which was a pathologist, and this is the first classification ever of renal disease, which came up in 1914. So it's always the nephrologist and the renal pathologist. You cannot work on your own. Pathology is a clinical discipline because you do reach a diagnosis, and this was told to me when I was just a resident. So pathologists are diagnosticians, and in order to make a diagnosis, you need history, examination, and investigations. You know this from our medical school. Unfortunately, our glass slides are not going to talk to us. مهما خدت السلايد الازاز وقعدت قلبتها يمين وشمال، هي لا هتقول لي الهيستوري ولا الاكزامينيشن ولا الانفستيجيشنز. So I need you to tell us the history, the examination, and investigations. And you need to give us detailed, relevant history and examination. Onset, chronic medical problems. I don't know why you always think that if the patient is diabetic, this is not an important issue we need to know. Or if the patient is hypertensive. No, we need to know if the patient is hypertensive or diabetic, even if you think that the current situation of the patient is not related to his chronic medical problem. We need to know the medications. We need to live in family history. We need to know all positive clinical signs. Is the patient edematous? Do you have any rash? Is there any peculiar lesions or other symptoms in other systems rather than the kidney? You need to provide proper demographic data. Age makes a lot of difference. It makes a difference. Diseases in children are not the same as in adults. Sex makes a difference, and so on. We need basic lab evaluation. And a basic lab evaluation does not mean a proteinuria 3+, because this is not a test. This does not tell me anything. Heavy proteinuria doesn't say anything as well. You need to put the number, how much it is, and by which technique. Is this a collection sample, or is this a protein creat, or is this a spot detection sample? You need to give us renal function tests, urine analysis, whether you have red blood cells, granular costs, whether this is an active urinary sediment or not. You need to give the immunological profile if you've done it to the patient, or if it's still pending. You need to tell us about the virology status and about the CBC of the patient, whether you've done PTH or not, and so on. This type of form is not optional. It's not maybe. This is a must. This is a referral form. And by the way, a lot of centers here in Egypt refer to us this referral forms, and I'm very proud of them that they do this, and everything is written and all the information are provided. And these are the centers outside of Cairo, actually, because the ones in Cairo, we don't get as much detailed information as the ones we get from the ones outside of Cairo. But as you see, this is just an example of how a referral form for the renal biopsy should be. This is not clinical data.
دكتوره وسام،
renal biopsy.
دكتوره وسام، انا عاوز اقول لحضرتك على حاجه. هو الطبيب المفروض يحط في دماغه ان الهيستوري والاكزامينيشن انفستيجيشنز ار مانداتوري عشان يعمل بروبر ديفرنشال دايجنوسيس. وهو ما يكون ثينكينج ان ا جود واي، هو بيحط قدام حضرتك الداتا، وان هو ثينكينج ان الدايجنوستس ممكن يبقى كذا وكذا، لان ممكن حضرتك الباثولوجي يبقى استونيشنج للنفرولوجيست، لا انا مش مفسر لي الفايندنج اللي انا لاقيها. فمن الاول لازم يبقى الاثنين اون بورد ان ممكن يبقى ديفرنشال دايجنوز كذا. فاحنا ساعات بيبقى من البيزي سيرفيس انه الريزيدنت او احنا ساعات بيبقى الواحد في عجله من الامر، وده مش صح، لان الداتا مهمه جدا جدا. ويمكن هيجي وقت نعمل سيشن كلينيكو باثولوجي ونوري ان الداتا بتفرق في الدياجنوزس والمانجمنت.
Please, yes. Now this is what I'm saying. Renal biopsy from a patient with proteinuria لا تعني أي شيء على الإطلاق. By the way, patient with a rising serum creatinine again absolutely means nothing. What is a rising serum creatinine? يعني till where? يعني is this a creatinine of 10 or 7 or 2.5 or 1.8? What is the rising serum creatinine? Hypertension, impaired renal function. Seriously? And one of my favorites, I get requests with query nephrotic syndrome, query lupus nephritis. Nephrotic syndrome and lupus nephritis are actually clinical diagnoses. I cannot tell you whether the patient is nephrotic or not. So don't write this to me, that it's query nephrotic syndrome. And of course, the best one is a core biopsy from the lower pole of the right kidney. And this simply excludes all the disease which is going to happen in the left kidney, which is of course 0. So I don't know what this sentence means, but sometimes you get this. Okay, so please know the clinical data are empirical. They are not optional, they are mandatory. And proper clinical data, these examples and these sentences are not considered any form of clinical data. Add your clinical diagnosis. انت ما بتغشش الباثولوجيستس عشان برضو ناس كتير قوي عندها الكونسبت ده. No, say what you're suspecting, because this saves a lot of time. If you're suspecting amyloidosis, then, and if the lab you're sending to does not perform routine Congo red, then they're going to do it from the beginning. If you're suspecting light chain disease, then they are going to do for you Kappa and Lambda. If you are not suspecting that the patient is lupus, you're going to be reported that this is a hot, urgent case and be careful because it's in your mind.
اسمحي لي مداخله صغيره هنا يا دكتوره وسام. هو امتى الواحد يبلايند الداتا للباثولوجيست؟ اذا كنت بعمل ريسيرش وعاوزه ابلايند ده ريسيرش بيربوسز، لكن في كلينيكال ورك وشود يعني ريبورت everything and the differential diagnosis، علشان ده هيوفر وقت وهيقلل وساعات بقى يعني لما بحط الصوره كامله قدام الباثولوجيست بيحاول يكزوست هيم سيلف كلاريفاي واكسبلين الفايندنج كلينيكال. لكن البلايند ده مكانه الوحيد الريسيرش والاهداف محدوده، لكن الكلينيكال اكتيفيتيز كلها او كلينيكال ورك كله لابد يبقى على داتا كامله. مفيش كلام.
Let me give you an example. يعني زي ما حضرتك بتقول، يعني we get, for example, a biopsy from a lupus patient and it says that the patient is proteinuric وعندها low C3 and C4. And then I see class 5. But because you reported that the patient has a low C3, C4, and you report that you're suspecting activity, we exhaust ourselves in each single glomerulus to make sure that the patient does not have a focal activity. If you don't add this info, then this biopsy can just simply pass as class 5 lupus. So yes, it makes a difference. We do an effort to try to interpret what's wrong with the patient.
Yes.
You are taking the biopsy because you have a question which you needed to be answered. So ask the question. Ask the question. Why are you not asking it? If you want to know why the patient is proteinuric, then say that the patient is proteinuric and he has heavy proteinuria and that you're suspecting amyloid or membranous. If you don't want to know why the patient have a high creatinine, then ask the question in order to get an answer. Another very important thing is that please mention previous pathological diagnoses because it does make a difference. It does make a difference. So the only patients I get previous pathology diagnosis in are lupus patients when it doesn't make a difference. When it's the only disease where the previous pathological diagnosis doesn't really make that much difference. But otherwise, if the patient has a previous biopsy or a previous histology or any info, please mention it. And mention that at least the patient had a biopsy before. Consider double pathologies and consider underlying diseases. And most important, share the information and discuss the information with your pathologist because this information needs to go both ways. So as I said, you need to include what do you want to know from the renal biopsy. So this is from the beginning. Before you take the biopsy, you need, and this will dictate what techniques you mostly need from the biopsy. If you don't have the ability for a full study, including immuno and electron microscopy, request biopsy accordingly to your differential diagnosis, write a full detailed sheet, and communicate with your pathologist. If you don't like the report, just communicate with your pathologist. Tell him this diagnosis does not fit with my patient. In the report, you should get whether the specimen is adequate or not. So this includes the size of the core, cortex or medulla, and the number of glomeruli. And the report is going to comment on the 4 compartments of the kidney, giving you an idea of the active versus chronic status of each compartment. So glomeruli, tubules, interstitium, blood vessels, which includes arteries and arterioles. And if this is a transplant report, then we also comment on peritubular capillaries. Remember that these compartments are not separate compartments. So what happens in the glomeruli is going to affect tubulointerstitium and vice versa. So you can get tubulointerstitial changes which are related to the glomerular pathology. And you can get glomerular changes which are related to the tubulointerstitial or the vascular pathology. And that you can get some diseases causes multiple affection. If this is diabetes, then if it's a diabetic nephropathy, then you're going to have a glomerular disease, a tubulo and interstitial, sorry, glomerular pathology, a tubulointerstitial pathology, and vascular involvement. Same for hypertension, same for lupus, and so on. So these are not separate compartments. It's not because you only have a clinical suspicion of a glomerulonephritis, then you don't expect that you're going to have tubulointerstitium or vascular changes, and vice versa. And some patients have more than one disease. This also happens, by the way. So the patient has an underlying disease like diabetic glomerulosclerosis, for example, and then develops something else along the way, membranous amyloidosis, whatsoever. So also it happens that you can have 2 diseases. The most important thing is that don't only read the diagnosis in the report, don't only look at the glomeruli, because your prognosis lies in the tubules, interstitium, and in the blood vessels. Not only your prognosis, but your management decision. It's the status, as we're going to see later on with each disease we're going to discuss, inshallah, as that basically the decisions of the management, how aggressive you should go and how long you should go, and that most prognostic factors and outcome-related factors actually lies in the tubulointerstitium and in the blood vessel compartment. So in the pathology report, look at the status of the tubules, interstitium, and the blood vessel if it's not written for you in the. Why is this? All of this is important because you have to understand that pathologists look at a structural damage pattern, not a disease. We look at a pattern, a response from the kidney to its injury. This is what we see under the microscope. So we look at a catalog of different pictures representing different patterns of glomerular response to injury. This is renal pathology. We don't look at a disease. What makes it a disease is the correlation with the clinical data and the interpretation of the biopsy. Then this pattern is changed into a diagnosis or a diagnostic disease. Why is this a pattern? Because one disease can have many different patterns of renal involvement, like lupus nephritis, for example, or you can have a single pattern with different underlying diseases, like proliferative glomerulonephritis, for example, which can be anything, IgA, lupus, post-infectious, whatever. So at the end, the interpretation needs experience in renal pathology and clinical nephrology and understanding of underlying pathogenic mechanism. So if your pathologist is not very much clinically aware, it's your role to teach them. It's your role to add up the missing clinical info in order to reach to the diagnosis which fits into this pattern and this clinical presentation. Let me give you an example of what I'm saying. We have 3 ways to look at biopsies. What do you think of these? ايه دول؟
الهرم اهو. ده هرم وده هرم بس.
ده هرم وده هرم وده هرم، مظبوط. حد تاني شايف حاجة تانية؟ واللي تحت هرم برضه.
واهرامات ومباني. لا طبعا
كله
كل
أهرامات.
حاجه كل حاجه لها شكل مختلف.
ده حقيقي، بس هو في الآخر كله
تراينجلز.
هرم. كله هرم أو تراينجلز. ده الهرم بتاعنا.
تمام.
بالظبط. وده الهرم، وده الهرم بتاع المكسيك المدرج. And this is the glass pyramid in front of the Louvre. And this is the prism. So although they all look like pyramids, they are completely different things. So this is it. This is a pattern. This is what we mean by pattern. It looks like this, but that does not mean that they are the same. Yes, exactly. If it looks like a pyramid, it can be any one of these 5 things and it still look like a pyramid. A second way, which is a very common way, and we see it a lot, is let's see what is in the histology. So we go with a systematic analysis. We describe the interstitium, tubules, glomeruli, vessels, then fit them into one of the categories. So we decide whether this is a primary glomerular disease or tubulointerstitial or vascular, and then we put a pattern. No change, FSGS, focal proliferative, diffuse proliferative, MPGN, depositions, etc. This is a diagnosis, but this is a descriptive diagnosis. This is morphology. This is not diseases. This is a morphological diagnosis. We cannot call this a disease. أمال نعمل إيه؟ Third way, which I call it the highway. You take it systematically as a clinical question. This is the right way to do it. A good history gives you a differential diagnosis. Systematic examination, knowing what you're looking for and why. Narrowing the possible diagnoses, try to identify the primary site of injury, answer the questions for which the clinician needs answers. So give a histological diagnosis. Grading and scoring. If immunity are they going to add? Ask yourself this question and add the info to it. So this is how renal biopsies should be interpreted, via a differential diagnosis, via a very systematic examination. You have to have a differential diagnosis in mind. You need to know what you're looking for. Why? Now, just do not put any descriptive or morphological diagnosis irrespective of the clinical presentation of the patient. This is your best to get to, but you must know the pathology has its limitations. So as much as you can avoid guessing, you can always suggest, but not guess. This is for pathologists. No need to guess, because you have to know your limitations. You have to know that you're limited within this biopsy, and your limitations are almost also based on the techniques you see. So if you're only using light microscopy, then you're more limited than using light microscopy and Immunopathology, or when you have a full study with electron microscopy. So to summarize, we have prerequisites for a correct diagnosis. Adequate biopsy, as I said, minimum of an 8 up to 10 course of biopsy as early as possible. We do not keep the patient for 2 to 3 weeks where you are giving all types of management and then biopsy and then want a diagnosis, because usually you're not going to get a conclusive diagnosis. I know sometimes it's unavoidable. I know we all get referred patients, or we all get patients when it's too late. But if you have the patient from the beginning, please biopsy, then do whatever you want to do with the patient. The early you get the biopsy, the earlier you take the biopsy, the more chance you get a diagnosis. Make sure that your biopsy is heading towards a place where it's going to be properly handled. Yes, it's your responsibility because it's your patient. And you're the one who's subjecting your patient to an invasive technique because you're the one who needs a diagnosis in order to be able to treat the patient. So do it right and do it to the end. So do a bit of an extra effort and a bit of an extra thinking and direct your patient properly. Professional data, and make sure that your biopsies are seen by an experienced pathologist. And more important, make sure that you understand what your pathologist is writing to you in the report. So it's we are not going to do all of this, which we've been discussing for 2 hours now, and then you get a report which you think you don't understand anything from it, and you just put it aside and then do whatever you want to do as if you did not take a biopsy from the beginning. And we all know that some of us has the capacity to do this. So no, don't do it. You don't have to do it. If you don't understand what's written in the report, just call up the pathologist and ask, and tell them, frankly, I don't understand what's this. Give me something to work with. And yes, and so you need to be knowledgeable with the diagnosis, with what is written, and better with the language the pathologist is trying to communicate to you. So the most important thing is that we all speak the same language. We use the same definitions. We use the same classification. We use agreed upon scoring systems. It doesn't make a difference if it's the most updated or the most recent classification. What makes a difference is that we understand each other, is that the pathologist understands what you're saying and that you understand what the pathologist is trying to tell you. We are not in a competition of what is modern and what is up to date. We are in a competition to treat our patients. So this is the target. Upgrade systems, but make sure that you still speak the same language and that we still understand. And always remember that with renal biopsy, you're only taking a snapshot at a time. You're only seeing one phase of the story. And it's up to you if you want to catch it early, if you want to catch it in the middle, or if you want to catch it when it's too late. Thank you.
انا مش لاقي كلام اشكر حضرتك بيه يا دكتوره وسام. يعني فعلا انا مستمتع لاقصى استمتاع. يعني انا عاوز بس تعليق بسيط. حضرتك اطلت جامد جدا فعلا في مفهوم البيوبسي، لان البيوبسي ده انا بقول للعيان وانا باخد منه كونسنت ان دي عمليه، وان انا بخضع العيان للعمليه بعد ما افهمه الكونسيكونس، فلا بد اخد منها الماكسيمم بنفيت باقل هارم ممكن. احنا مش احنا we are not competing together, we are complementing شغلنا. يعني we are complementary rather than competition.
لا انا قصدي ان احنا مش نكمبيت ان احنا نبقى مور ادفانسد وكده.
لا يعني لا انا بكمل يعني انا بحط تحت المفهوم اللي حضرتك بتقوليه. متفق مع حضرتك 100%. المفروض ان احنا يعني حتى الانستتيوشنز اذا كان على الناس، بعض الدكاتره بتوع الكلى اللي معانا على الهواء دلوقتي او اللي هيسمعوا البرزنتيشن في انستتيوشنز او يعني معاهم قريبين من الباثولوجيست بتاعهم، يا ريت يبقى في يبص مع الباثولوجيست اذا تيسر هذا الكلام، بيتربي ثقافه. يعني احنا لو وحدنا اللغه زي ما حضرتك بتقولي، انا ابقى فاهم. انا عمري ما هقرا الباثولوجي، يعني عمري ما هريبليس دكتور الباثولوجي في قراءه البيوبسي، ولا عمر دكتور الباثولوجي هيريبليس شغلي. احنا هنكمبلمنت بعض بحيث ان احنا شغالين في تيم يبقى 1 زائد 1 يساوي 10. لكن لما كل واحد يشتغل في اتجاه، انا فاكر استاذنا الدكتور المرحوم الدكتور كمال الدين احمد كان رئيس جامعه المنصوره، وانا حضرته وانا يعني في اخر ايامه، يقول انا ممكن افضل يوم كامل ما اناش عارف ده انفلاميشن ولا تيومر. فالقصه ما هو الباثولوجي صح، احنا بنتخيل ان هو بيتقرا لوحده، ما بيتقراش لوحده. فلا بد من داتا نعملها، ولا بد يبقى في لغه بيننا. وزي ما قلت في الاول، دكتور الكلى اللي ما بيعرفش باثولوجي ما هوش دكتور كلى شاطر، والباثولوجيست نيفروباثولوجيست اللي ما عندوش فكره عن الكلينيكال اكتيفيتيز ما هوش دكتور، مش باثولوجيست شاطر. فلا بد ان احنا، لان ده جزء من الديوتي بتاعتنا ان نبقى بروفيشنال. تبقى بروفيشنال لازم نأوير بهذا الكلام. انا لو في اي اسئله على الشات قبل ما نقفل بقى اللقاء الممتع يعني فعلا لا يقدر بثمن يا دكتور وسام بصراحه.
الله يخليك يا دكتور حسين، ده من ذوقك، ربنا يخليك، شكرا. لو في اسئله.
في واحد باعت سؤال ليا كدني بايوبسي بيتر تو بي دون باي اكسبيرت راديولوجيست نوت باي نفرولوجيست. طبعا لا، هو معظم الوقت بيستسهل وخاصه في الانستتيوشنز وبيخلي الراديولوجيست يعملها. لكن اذا يعني انا ما كنت نايب كنت بشتغل بايوبسي مع الجماعه بتوع الراديولوجي، كانوا بيسيبوني اشتغل لان انا كنت متحمس. لكن اذا كنا بنفكر ازاي نحسن النفرولوجي، فالمفروض الدكتور الكلى اللي يعمل البيوبسي، والمفروض ترجع تاني لانه هيبقى عارف العيان بتاعه والميديكو ليجال ريسبونسبيلتيز، وهيبقى حساس مع البيشنت ده، عارف انه ده هيبليد، فيبقى فيري جنتل ويعمل له البريكوشنز. فهو الافضل ان النفرولوجيست هو اللي يعمل البيوبسي. ان ما كانش، اذا كنا احنا في الانستتيوشن الانترفنشن راديولوجيست هو اللي بيعمل، اتس اوكي. لكن احنا لو استعدنا البيوبسي ديت في كل الانستتيوشن نفرولوجيست يعملوها يبقى شيء كويس جدا. لكن لو انا في برايفت وما عنديش الفاسيلتيز، طبعا السكيورتي بتاع البيشنت في المقام الاول، لان ده انفيزيف مانوفر should be done by the best hand اللي تعمله. اذا كان ده نفرولوجيست اوكي، راديولوجيست اوكي. يعني مثلا عندنا على سبيل المثال احد الكاتيجوريز الفيري ريسكي البريجننت ليديز. احنا عندنا ناس بروفيشنال في الراديولوجي، هم جزء منهم ما عملش خالص البريجننت ليديز بايوبسيز، رينال بايوبسيز. لا يمكن اوافق ان حد ما عملش لست حامل قبل كده بايوبسي يعمل لها، واذا ما كنتش انه في ريسك مش هعمل. فدفع الريسك او الهارم مقدم على اي حاجه. والاحسن ان احنا نتعلمها ونعملها. رايك ايه في الكلام ده يا دكتوره وسام؟
طبعا انا موافقه تماما. انا برضو الجنريشن اللي اتربى على النفرولوجيست بياخدوا الرينال بايوبسي، وكان بيجي لي دايما كومنت: البايوبسي احنا خدناها الكدني التيشو شكله لونه مش مظبوط، التيشو شكله دراي، تفتكري هيطلع فايبروتيك. This was all the comments of the nephrologists. I stopped getting all of these comments when we started switching to radiologists. Radiologists are fine، بس زي حضرتك قلت تفضلت ان هو they are not their patients. You know your patient and you know what you want to know from the biopsy.
يعني احنا بنكمل الشغلانه دي عندنا مثلا. يعني انا بكلم الدكتور الاشعه بقول له ارجوك ده خليك فيري جنتل هنا، يعني خلي بالك، لانه احنا بنكمل بعض. لكن لو انا تريند ويل على البيوبسي وبعملها، انا هبقى عارف كل الكلام ده، وهبقى اكثر حرفيه لو انا متمرن عليه.
مفيش اي مانع انه يبقى ان اكسبرت راديولوجيست. هي في راديولوجيست هايلين وبياخدوا متعودين انهم ياخدوا رينال بايوبسيز وايديهم كويسه وكل حاجه، بس بقى هي نفس الفكره ان انت لازم دي بقى وظيفه النفرولوجيست. دلوقتي انت بعت لحد ياخد لك البايوبسي بتاعتك، فthen you should add all the guidelines as we have discussed.
السيفتي مقدمه. انا علشان طبعا تعبناك
ازاي تقول له انت عايز تستعمل تحليل وعايز التست ايه وكده،
وارهقنا حضرتك معانا. الدكتوره دولت لو حضرتك لك تعليق اتفضلي يا دكتوره دولت. دكتوره دولت
هي محتاجه حد يعمل لها اميوت متهيألي دكتور حسين.
In UK it's nephrologists who do the biopsy, it's okay. يعني في اليوكي النفرولوجيست اللي بيعمل. واعتقد في امريكا من 20 سنه لما طلعوا الانترناشونال سوسايتي اوف انترفنشن نفرولوجي بتحاول ترجع التكنيكس، لان ده هيقلل شويه البرن اوت وتخفف شويه ان ما يبقاش شغلنا كله بيبر وورك، لا يبقى فيه برضه بروفيشن، لان عمل البيوبسي ده برضه او تكنيك وحاجه زي كده. فاعتقد ان احنا المفروض نتقن الشغلانه ديت. لكن لو انا ما بتقنهاش وما عنديش الفاسيلتيز، اروح للي يعملها لي فيري سيف، لان السيفتي وذ بيشنت مقدمه على اي حاجه ثانيه. انا في نهايه هذه الحلقه الممتعه جدا اللي حطت نقط على الحروف في البيزكس اوف نيفروباثولوجي، وانا كنت متخوف ان حضرتك تتكلمي من النيفرولوجي بوينت اوف فيو، لان احنا مسجلين محاضره على الرينال بايوبسي من النيفرولوجيست اسبس. ما شاء الله محاضره ممتعه، بشكر حضرتك. وان شاء الله لو وعد
ميرسي
هنرتب مع حضرتك في الاسبوع اللي جاي الحلقه ان شاء الله نعمل
ان شاء الله.
هنعلن عنها ان شاء الله من السبت او الحد. وبشكر كل اللي معانا، وتصبحوا على خير، ونشوفكم دايما على خير يا رب. السلام عليكم.
تصبحوا على خير وميرسي جدا. وعليكم السلام ورحمه الله.
شكرا دكتور وسام، شكرين.